We are live.
So, good evening, everyone, and thank you for joining today's meeting. I would like to introduce our first speaker for today's meeting, Dr. Sonal Lakdawala Jadhav, a veterinary surgeon from Mumbai. She completed her DO and DNB in ophthalmology from Sion Hospital and her veterinary fellowship at the Retina Foundation under Dr. P.N. Nagpal. She has worked as a consultant at Aditya Jute Eye Hospital and Bombay City Eye Institute and is currently the medical director for Panorama Eye Clinic, focusing exclusively on vitreoretinal care. Dr. Sonal has been faculty at several local and national conferences and presented posters at international conferences. And with this, I warmly welcome Dr. Sonal for her presentation. Over to you, ma'am.
Thank you so much. Thank you, Team Bayer. Thank you, Roshali. Thank you, Sushil, for this kind invitation. It's always a pleasure to talk on this platform. Can I just start sharing my presentation?
Yes, ma'am.
Sure. Going to go on the slideshow. So, with a gamut of so many anti-VEGFs that we have in our kitty today, and obviously looking at our major factors, that is patient compliance, the increase in your or the maintenance of your best corrected visual acuity, presence of intraretinal or subretinal fluid, how to maximize the treatment, do we follow a treat and extend regimen, or do we do a PRN? So there are so many questions that are there in the mind of retina surgeons, and I think a lot of these also depend upon your practice over the years and the way you look at patients. At the same time, how you would strategize for maximizing the treatment durability. But today we talk about the treat and extend approach with aflibercept. As we all know that aflibercept, the VEGF signal, which is the main cause, there is an increase in the VEGF and the placental growth factors, which leads to a hypoxia, the VEGF-A, VEGF-B, which has the VEGF-R2 and the VEGF-R1 arm, and they cause excessive activation of the inflammation, neovascularization, and the retinal vascular leakage and edema. I'm just going to... Give me 1 second. I'm having some small window which is coming in my way. So, Sushil, just 1 minute.
No problem, ma'am. Yes.
Yes, because it's coming in my way. Yeah, this is absolutely fine. So as we know, the aflibercept molecule, it has pioneered a multi-targeted approach over a decade ago. And the molecule itself has a light blue arm and a dark blue arm, which binds with VEGF-A, VEGF-B, galectin, and PIGF. And then also the VEGF-R2 domain, which binds with VEGF-A. Both help in reducing inflammation, neovascularization, and leakage and edema. And also has a small FC portion on its arm, which extends its half-life. Aflibercept has been extremely well tested in real-world clinical practice, and it's established as a drug in retinal vascular disease across the country, across the world. A lot of trials have been done. There are randomized trials and real-world trials. It has demonstrated an unsurpassed durability with its proactive treat and extend regimen, extending over up to 60% of patients when you can extend the treatment up to week 12, and up to 46% of patients where you can extend the treatment over 2 years at an interval of 16 weeks. So being a long-term disease which requires consistent treatment to maintain your vision outcome, overall lesion reactivation, we've all seen that when we do not continue the treatment, or eyes that resume a treatment after the lesion is reactivated, or there's a recurrent activity and there's a recurrence of fluid, there is definitely a mean net loss of 3.3 letters for these patients. So the point is that here, how do we tell our patients that continuation of anti-VEGF therapy is extremely important even in stable patients, and how can we maximize these treatments and not go into a loss of vision if we have done very well with our initial loading doses. Anti-VEGF treatment burden should be minimized without compromising patient vision. We saw in the Asia-Pacific region in the APVRS consensus and recommendations that a lot of patients had to commute vast distances, and that's how compliance got affected. A lot of patients were directly paying or indirectly paying out of their pocket, and insurance companies were not funding it. That also reduced the compliance. Patients who are living more than 60 kilometers and have a higher risk of being continually non-persistent to therapy. So at this point, if we can have a treatment and a treat and extend regimen where every visit is a treatment visit, and that takes care of our patients, and then as we go ahead, we go on increasing the doses, I mean the number of weeks, it will help our patients to maintain their vision and not cause a visual loss. A lot of studies had been done, randomized one-to-one trials were done, and the two main one which was done by aflibercept or with Bayer was Aries and Altair. Aries was done in treatment naive NMD and Altair also, and they were both 1:1 trials where in Aries it was an early start where initially 3 loading doses were given, and then the injection interval was adjusted by a 2-week increment, and there was a fixed dosing at 8 weeks up to week 52, and then the interval again was adjusted by 2-week increments further up to week 104. But in Altair we had a 2-week initial adjustment, and then we could increase it to 4 weeks over the next 1 year, which is week 96. So from week 52 to week 96 we could go ahead to 4 weeks. When these studies were done, what was observed that was that at the end of 52 weeks and 96 weeks, both the studies, the mean change in visual acuity did not really change much. The primary endpoint remained somewhere same, whether the patient was treated at a 2-week adjustment and then later at a 4-week adjustment also. So Altair did help in, maintaining vision with fewer injections in year 2, and that was a very big advantage that was seen. So as we see in week 52 and week 96, in the mean number of injections in the 2-week group were also 10.4 and 4-week group were also 10.4. So that made a lot of difference to us, and it gave us a lot of confidence to go ahead and extend the intervals in a lot of patients. By week 96, about 56 to 60% of patients were maintained at in an interval of 12 weeks and beyond. And the mean interval in a 2-week group and a 4-week group was somewhere the same. Patients' compliance was very good. The last injection interval at the final visit also was absolutely perfect, and there was no need for the patients to follow at 8 or 10 weeks. We could jump to 8 to 12 weeks and 12 to 16 weeks. So in Altair, almost about 96% of our patients, we could extend up to 16 weeks, and we realized that almost about 85.8% patients maintained their vision and also were compliant with the treatment. So patients, the proportion of patients that extended their treatment and maintained their vision was almost 85.8% when the interval was increased to almost about 16 weeks. Aflibercept also achieves vision gains which are maintained in the long-term NMD. So when you see these patients over proactively getting treated for almost about 2 years and then 3 years and 4 years with continuing dosing, we realize that the primary endpoint at the 52nd week and almost at 96th week were both the same at 10.4 and 10.2. So the mean change in visual acuity was not much. And even if it was at 4 years, the mean change in visual acuity did not really drop to a large extent. Patients did maintain their vision. So this range or this follow-up study gave us a gain with aflibercept, which maintained our treatment patterns for almost 5 years. Let me look at a lot of clinical cases, and one interesting clinical case that I'm going to share with you today was this patient who was a 75-year-old male. He came to us with diminished vision in the right eye, vision dropped to 624 N18, and he was diagnosed with an IPCV on 19th of September 2024. No other systemic illness, and came with just this. The left eye was absolutely fine. We gave him the first injection, and the response was any which ways wow with Eylea, which is what we have seen. So 1 month later, the vision improved to 612 and 12, and then the second loading dose was given on 24th October 2024. He came back after a month where I gave him the third loading dose in 27 November, and vision again improved to 6, 9, and 8, and the entire subfoveal hemorrhage had decreased, and you can see the blood coagulating completely. As we went ahead, the response after the third dose, a month later, when we again watched him, when 3 loading doses were completed, and on 26 December, we decided to ask the patient to follow up exactly at 8 weeks and now jump after 2 months with a treat and extend regimen where vision was maintained at 6, 9, and 8. This patient came back to us in February, on 25th February, and a recurrence was noted. An injection at the 8th week, injection Eylea 4 was given at that time after the 3 loading doses. So he was injected at 8 weeks, that was there. He was then again asked to follow up after 1 month, and there was no fluid in March, and the right eye showed like a scarred fibrovascular PD. And I extended the interval back to 8 more weeks because vision was well maintained at 6, 9, and 8, and the treat and extend regimen then continued. In April, when he came back after 2 months, there was no fluid, and a treat and extend regimen and injection Eylea 5 was given at that time. So at this point, patient was doing well. There was no fluid. I was at 8 week intervals, and I decided to treat him at every time that I saw him. At this point, I decided that as he is doing well now and the vision is maintained, I can observe after 8 weeks, but if there is no fluid, I would jump to an interval of 16 weeks. He came back after 2 months, fluid was not there, vision was maintained at 6, 9, and 8, and I increased the interval to 4 months and asked him to follow up in August 2025. In August, when he came, the vision had slightly dropped to 6, 12, and 12. It was exactly 4 months, 16 weeks, and an Eylea 6 was given at that time. At this point, also, there was no need for me to go back to an 8 week regimen because I could watch this patient again back at 8 weeks, and if there was no fluid, I could still continue the interval at 16 weeks. Back after 2 months in October, when we watched him, there was no fluid. And then when we watched him back in November, which was exactly at 16 weeks, vision was maintained at 6, 12, and 12. There was no fluid. It was a scarred fibrovascular FAD, and an Eylea 7 was given. He's now asked to follow up at 16 weeks in March 2026. So if at times when we see such patients and we realize that even after increasing the interval, they come back with a recurrence, it is not necessary for us to go and jump and decrease our intervals, because sometimes you can just go on observing these patients and keep the intervals at 16 weeks, and our patients genuinely do very well. So this also gave me a lot of confidence while I was treating my patients with aflibercept, and there was a lot of patient compliance at that time. There was a study that was done from Moorfields, which demonstrated that vision gains that were achieved with aflibercept were very, very well maintained after 1 year, and up to almost 4 years with continued proactive dosing. So you see the mean visual acuity at the end of 1 year in almost 61% of patients from 7.8 to almost at about 4 years. The number of injections had decreased. Over the first year was 7. Over second year, you increased only by 5 more injections. Over 3 years, we increased by another 4 injections. And over 4 years, we increased by another 3 injections. Almost 52% of our eyes were being treated at an interval of 12 weeks, maintaining the BCVA from baseline almost up to year 4. Again, another study was done by Train et al., which demonstrated that proactive treat and extend dosing with aflibercept led to a long-term visual acuity stability and prevented loss in majority of patients. Here also, the visual acuity did remain almost from 5.7, dropped a little to 3.6 over 4 years, but the number of injections were 7, 12, 16, and 20. So almost about 46.9 to 49% of patients were treated at an interval of 12 weeks and beyond, and they maintained their vision. So a lot of these studies increased the gave us the confidence about the durability of aflibercept. Now let's look at a few other anti-VEGFs that were coming also into the picture. A lot of real-world studies were done by Moorfields, Train et al., Jaggi et al., and they were compared with your randomized clinical trials with ARIES and ALTAIR, and we realized that almost in most of these studies, at an average of more than 12 weeks, 58.5% or 52.5% or 46.9% patients maintained their vision, and at an interval of almost about 12 weeks and beyond. Let's come to a new drug that has been in the market, and it has been giving us also some results, but brolucizumab, which is the only new drug that has been introduced by the Novartis company, also did 2 studies, the Hawk and the Harrier. But in these patients, it was noticed that almost about only 39 to 45% of patients were maintained on 12-week dosing. One was that the drug required over the 2 years was a higher drug concentration at 6 milligram. The number of injections required were the same. 6 milligram brolucizumab were 10 injections over 2 years, and an aflibercept was at about 11.7 injections. Despite the option to extend the intervals to 12 weeks, most patients treated with brolucizumab received fewer injections than those receiving aflibercept on a fixed 8-week regimen. So the study did not really match too much, despite the relatively high molar concentration of brolucizumab and its effective small weight. It had a shorter intraocular half-life, but it cleared from the eye quickly. And we realized that only about 39 to 45% of patients maintained on week 12 dosing up to 2 years in Hawk and Harrier. So the drug required was more, the risk of intraocular inflammation was more, and the compliance of the patients had decreased in these patients. And obviously, cost also came into picture. There was another study that was done for a newer drug that was introduced by Roche, which was called as faricimab, which was again requiring a 6 milligram dose and increase the treatment burden compared to aflibercept, because here you required 4 loading doses. That was the first thing. There was a higher volume of the drug. Cost came into picture. The kind of study that Tenaya and Lucerne did was they did not match the study well, because they increased the faricimab drug at 12 weeks and 16 weeks, but they kept the other arm of aflibercept only at 8-week dosing. Owing to that, the study did not give the right reports, because they never increased the aflibercept to 12 weeks and 16 weeks. So it was not something that was very well accepted. Durability with aflibercept, the Tenaya and Lucerne, as I said, that the Q8 intervals were not permitted with aflibercept, and obviously faricimab, we needed a higher volume with 4 loading doses compared to aflibercept, which required only 3 doses. So when we explored the durability of so many anti-VEGF agents, we come to a summary where aflibercept provides clinically meaningful visual outcome with unsurpassed durability and reduces our treatment burden. So when you look at the first molecule, that is ranibizumab, which was introduced as the primary drug by Novartis, 17 to 43% of patients achieved treatment intervals of 12 weeks beyond 2 years. For patients treated with bevacizumab, only 10% reached an interval of 12 weeks and beyond over 2 years. We saw Hawk and Harrier, only 39 to 45% of patients were maintained on week 12 dosing with brolucizumab, and that to a higher drug at 6 milligram by week 96. In Tenaya and Lucerne, patients almost about to 39, 34%, 32 to 34%, and 44 to 45% of patients on faricimab were adjusted on week 12 and week 16, respectively, but all aflibercept were maintained on Q8 with no option for extension. So that was an inappropriate comparison of the treatment burden with these two agents. In contrast, up to 52% of our patients in ARIES extended to week 12 and beyond, and 30% of our patients extended to week 16 by week 104. And Altair, 60% of our patients extended to intervals of 12 weeks and beyond, and 40% to intervals of 16 weeks maintained their vision with patient compliance. A lot of real-world studies, as I said, of aflibercept have also been done by Kataoka et al. Or Kishi or Hara. These are faricimab in Japanese population, and this treated patients switched from aflibercept to faricimab, and they kind of did these studies with these patients, and we realized that about 130 eyes which were previously treated with aflibercept were switched at 4-week intervals to faricimab. But we realized that in these studies, almost 60% discontinued their treatment from baseline to 6th month. 92% of our patients who switched from aflibercept to faricimab did not continue the treatment due to insufficient efficacy of faricimab. Okay, there was no change in visual acuity. There was minimal change in the central retinal thickness, and the treatment was not able to extend up to more than 8 weeks of intervals. And 73% of patients almost switched back from faricimab to aflibercept. Aflibercept is also a very well-known drug in PCV, and the monotherapy has been equally, achieving all the results, and meaningful visual outcomes have been seen in most of our patients. Here also, the endpoint in the mean BCVA over 1 year and 2 years, where there was a comparison trial done where aflibercept monotherapy was taken and aflibercept with active rescue PDT. Now we don't have PDT with us, but here also, if you compare both of them, the mean visual acuity remained good with even a monotherapy. So these across clinical trials, proactive aflibercept monotherapies have been able to achieve clinically meaningful vision in most patients with RPCV. Whole load of studies were done, real world RCTs, the PLANET study over 12 months, 24 months, and most patients maintained their BCVA from baseline. There was also eyes with complete polyp regression seen in most of these monotherapy studies where Planet was done, Walt was done, and aflibercept monotherapy, a Japanese case series. These were all done over a period of 3 months, 6 months, and 12 months. And obviously, we've seen in even my case how the entire fibrovascular PD settles down so beautifully with just simple monotherapy. So aflibercept provides unsurpassed vision gain with an excellent safety profile. The drug is equally very safe. I mean, I think as retinal surgeons, when you give an Eylea injection, you can be sure that you would sleep that night and not get worried. There are so many randomized clinical trials. There are so much real world data. More than 25,000 patients have been treated in these clinical trials and real world studies. Almost 7 million patients have been exposed to this drug. It is licensed in DME, NME, and AMD, neovascular AMD, CRVO, BRVO, CNV, NVG, all across the world, and I think DME and AMD in India. More than 50 million doses have been sold, and almost 1 decade has gone in clinical trials, real world, and post marketing experience. We also know that we have extremely less rate of intraocular inflammation, or a role of rate of endophthalmitis is just 0.6 in 10,000 doses sold. And so much data is with us that it becomes a benchmark for efficacy and safety in all our patients, giving us that wow effect when we inject the drug, and at the same time helping us to prolong our patients on treatment, save their vision, and help them also on long, especially with Eylea, with Bayer introducing this beautiful system where they started giving the first injection, and then after that the second became free, and then the third injection was given, and the fourth and fifth. So they also really helped a lot of retinal surgeons to go to Eylea and confidently give it in our patients. It has been a pleasure using this drug, and it is, as retinal surgeons, I think, the most important is when you give this drug, you want to sleep at night well, and you also want to be confident that you are going to take care of your patient and have a good compliant patient with you with keeping the vision very well. So I think thank you, Bayer, thank you, Eylea, for introducing a drug like this. We look forward to your new 8 milligram dosing, but till then, I think we are all very happy with Eylea. Thank you so much.
Thank you, Dr. Sonal, for the so much engaging and insightful presentation on the treatment experiment regimen and lots of insightful data on randomized clinical trials and the real world evidences. So thank you so much, ma'am.
Thank
And
you.
ma'am, just I would like to add one thing, ma'am. From 1st April, we are making Eylea more accessible, ma'am. We
Yes,
are reducing the price of the Eylea, and now
yes.
it will be available at a lesser price than the current
Yes.
one. So
So
upfront cost would be much lesser than the current one, ma'am.
we're looking
So
forward to that. We're looking forward to that. We're looking
sure,
forward to your 8 milligram molecule also, and we're looking forward to the new pricing that's going to happen. I'm sure you would do it in the best interest of the patient too.
definitely, ma'am. Sure.
Thank you so much.
Thank you, ma'am. Yeah, Sushil bhai.
Yeah, so our next topic is on how all anti-VEGFs are different in terms of like molecular differentiation. And for that, I would like to introduce our next speaker, Dr. Ruchi Wala. Dr. Ruchi Wala, Dr. Ruchi Wala is a veterinary surgeon based in Baroda. She completed her MS in ophthalmology from Sumandip Vidyapit University, Baroda, followed by a fellowship in Vittoretina and UVA from Narayan Nethralaya, Bangalore. She is currently associated with Wala Eye Center and several other hospitals. Dr. Ruchiwala has contributed to numerous national and international publications, particularly in ocular tuberculosis and uveitis, and has presented her work at forums like EURETINA and AIOS. So with this, I invite Dr. Ruchiwala for her presentation. Over to you, ma'am.
Thank you so much, everyone. Thank you for the opportunity. Thank you, Yash, and thank you, Bayer Company. Very nice presentation, ma'am. Sonal, ma'am.
Sorry, I was muted. Thank you so much, Ruchi. Thank you. Looking forward to yours.
Okay, I'm just going to try and see if I can share it. Okay, Mike, just give me a minute. My desktop is asking me to. Okay. Is it visible?
Yes, ma'am.
Okay. So today, after ma'am's topic, which focused more on the clinical aspect of the injection, I think what another aspect of the injection is the molecular characteristics. So my topic is beyond simple inhibition, the multifaceted molecular characteristics of anti-VEGF agents. It's not moving ahead.
Akash, could you please guide Dr. Ruchi?
It's coming, but then it's not moving. Okay, it's
now
moving.
it's moving.
It's moving. It's moving. Okay. So a disclaimer that this slides are only for the purpose of scientific and educational purposes, and many of the things have been sourced from an FDA review document. So in case anyone wants to review it, they are encouraged to review it for further insights. So as Sonal ma'am already said that the VEGF signaling pathway is the master regulator of pathological angiogenesis. We all know that there are two receptors, VEGF R1 and VEGF R2, and placental growth factor VEGF-A, VEGF-B. They causes activation of the receptor, causing excessive activation, inflammation, neovascularization, leakage, and edema. So in trying to understand how these molecules affect and how they interact when they are injected, there are a couple of things that are important to understand. One is the binding affinity, the elimination half-life, the potency, the clinical targets, and the molar dose. We'll be going through each one of in the following slides to come. So talking about the binding affinity basically determines how strong your drug is going to interact with its target. And it's measured through a KD value, which is known as a dissociation constant. Each molecule has a dissociation constant of its own. And from the data that was done with the head-to-head study, it was noted that aflibercept had 0.172 KD value. So lower your KD value, the higher the binding affinity. So aflibercept was found to have statistically higher VEGF binding affinity than brolucizumab and ranibizumab in a head-to-head study. Coming to the potency will determine the required concentration of a drug to produce a defined effect. So in this also, the value of the potency is determined through IC50, which is an inhibition concentration. And from the data, that is, the lower the IC value, the more the drug is potent. And when it is compared to other anti-VEGF molecules, it has been noted that aflibercept has the lowest 2.42, which shows the increased potency of aflibercept. And next is the most important, half-life. Half-life provides an insight into the drug concentration in the body over a period of time. And in aflibercept, it was noted to stay in the estimated human half-life of 9.1 to 11 days, which is a little higher than all the other anti-VEGFs available, which goes to say that the drug, the longer intervals at which we can increase the injection interval. And the targets, as this also was covered by Dr. Sonal ma'am, that different molecules have different targets that they can cover. So the single target molecules are brolucizumab and ranibizumab, while the dual target is the faricimab, which has VEGF-A and angiopoietin 2 targets. While we all know that aflibercept has a multi-targeted action on VEGF-A, VEGF-B, placental growth factor, and galectin-1. So this is a rough comparison of all the anti-VEGFs that are available with us, from the brand name to the molecular structure to the mode of actions, most common indications, the size, and the dosage that we are commonly using. Coming to the summary of more molecular properties, if you compare the molecular properties of all the major anti-VEGFs, then it has been shown that in most of the aspects of molecular properties, aflibercept is superior to other available anti-VEGFs. So, so far we have been talking about the VEGF pathway. Now, could targeting additional pathways beyond the conventional VEGFR pathway improve the further efficacy outcomes? So, aflibercept inhibits multiple targets. So, another signaling pathway, that is the placental platelet-derived growth factor inhibitor, was tried, and using some regorafenib eye drops and intravitreal denosumab, and no additional benefits were seen when they were compared to other anti-VEGF agents. So what about the inhibition of angiopoietin-2? Now, the regulatory comment of the relevance on angiopoietin-2 in retinal disorders, the FDA says that the effect and clinical response in neovascular AMD and DME has yet to be established when it comes to relevance of angiopoietin-2. Now, is the angiopoietin-2 Tie2 pathway a relevant target for the treatment of exudative retinal diseases? We all know that Tie2 receptor and angiopoietin-2 competes with the Tie2 receptor, and it binds to it, and it causes inflammation, vascular permeability, neovascularization. And in high VEGF state, it causes destabilization of blood vessels. However, in low VEGF states, which is induced by anti-VEGF treatment, angiopoietin-2 may have limited relevance. And aflibercept thus is the most potent binder of VEGF when compared with other available agents. To prove this, there was a study done by Bayer and Regeneron, and they investigated the angiopoietin-2 pathway in combination with aflibercept in the Ruby and Onyx study. Initially, the KD, that is the dissociation constant, was compared, and the Tie2 receptor itself has a dissociation constant of 3000 for angiopoietin-2, whereas faricimab has a very high KD, which shows that it has very lower binding affinity, whereas the new drug, the nesvasumab, which was tried by the company, it had a very strong binding affinity and had only the dissociation constant of 24. So the data from the different separate studies do suggest that nesvasumab is a more potent inhibitor of angiopoietin-2 than faricimab. Translating it into clinical translation, no additional clinical benefits were noted with angiopoietin-2 inhibition when it was compared with aflibercept. And this was seen in the Ruby trial, where the patients were enrolled for DME, and in the Onyx trial, where the patients were enrolled for neovascular AMD. Here, separately, aflibercept was given, and nesvasumab with aflibercept was given. The trials were continued till 36 weeks, and no efficacy improvement was noted neither in neovascular AMD or DME. Therefore, aflibercept with angiopoietin-2 program was discontinued. Faricimab also examined angiopoietin-2 inhibition in combination with VEGF, but did not offer any visual improvements over aflibercept 2 milligram. Other studies which were comparing directly faricimab and aflibercept were done. The studies were Yosemite, Rhine, Lucerne, and Tenaya, and the studies were done till an average weeks of 48 to 56 weeks, and the mean BCVA change was which was in patients who had received faricimab and compared to aflibercept, the vision gain was non-inferior. Also, one important point is that in faricimab, in a phase 2 trial of Avenue, what was noted is that when they compared it with ranibizumab, after the primary injection, single-dose injection of both the molecules, the levels of angiopoietin-2 was seen to reduce, and it was quite comparable for both faricimab and ranibizumab. So this data suggests that anti-VEGF monotherapy neutralizes angiopoietin-2 to levels which were comparable to that of directly targeting angiopoietin-2, supporting the known biological activity of angiopoietin-2, whereby its activity is downregulated by decreasing the VEGF-A levels. So in short, it was just trying to say that the reason why the angiopoietin 2 was coming down could be because of the anti-VEGF action alone rather than the anti-angiopoietin 2 production. So aflibercept has shown to be the most durable and robust suppression of VEGF and angiopoietin 2 when compared with brolucizumab and ranibizumab. The activity of faricimab may be derived primarily from its ranibizumab arm rather than the anti-angiopoietin 2 arm. So no proven clinical benefit has been shown with angiopoietin 2 inhibition. It could be the higher molar dose of the ranibizumab Fab arm that could be responsible for the faricimab treatment effect. So in summarizing the whole presentation, with aflibercept 2 milligram already targeting our main master regulatory VEGF pathway, and as the other pathways that has been shown in the presentation shows very limited potential, there could be limited potential for improvement in functional outcomes for the patients. Thank you.
Thank you, ma'am. That was a wonderful presentation, ma'am. Lots of insights. There's a question from in the chat. Dr. Patel, that what protocol do you follow for the treatment naive patients of wet AMD as well as DME?
Should I go ahead to answer that?
Yeah,
Yes, ma'am.
please do.
Yeah. So, Dr. Patel, as we are treating so many treatment-naive patients, I'm sure we all start with a loading dose of, I prefer a loading dose of 3 injections with aflibercept. I will follow a treat and extend regimen in my neovascular AMD cases, definitely. But in diabetic macular edema, I can go PRN. I don't need to follow a treat and extend regimen or anything over there. I think it is absolutely okay because you're controlling multiple metabolic factors for those patients. And at the same time, you don't really need a 3 loading dose kind of a thing. You can give 1 injection and observe the patient. But yes, I mean, if you give your initial injections as 3 loading doses when you have a lot of patients with large hard exudates and succinate maculopathy and a lot of CSME with CME, it does help these patients, but you don't need to definitely go to a treat and extend regimen in DME compared to a treat and extend regimen that you would definitely give for neovascular AMD. Ruchi, any inputs from you?
I follow the 3 loading doses followed by a PRN for neovascular AMD patients as well.
Okay.
For DME, we do try to suggest 3 loading doses, but it's not always possible. But the aim is to have 3 loading doses for AMD as well as DME.
Yes.
But I don't follow treat and extend. I follow largely PRN.
Yeah. Which I think is definitely something that you have to look forward to, because we have that kind of compliance for our patients where, we may not be able to do a treat and extend regimen for most of them. So I think sometimes it's also individual, patient to patient. You probably see your patient, you see the compliance of the patient, you see how much the patient is, understanding the disease and the importance of your injection.
I know.
Sometimes they just feel that, I just have to take 3 injections and I'm going to be fine. So I think that's also there. Yes.
I think I mean, on a lighter note, I have in my practice, sometimes I feel the efficacy and the compliance of the Eylea increases after the patient has switched from a biosimilar, and then we start the patient on Eylea, and the patient sees the wow effect of Eylea, and they keep coming back, and then the compliance sometimes automatically increases for us.
Right.
I have not yet injected faricimab so far in my practice.
No,
What about you, ma'am?
I have injected faricimab, and it was treatment naive DME. This was I kind of gave 4 loading doses in that eye at 1 monthly intervals. It's extremely heavy on the pocket. That is the first thing. And second is, it's also a little difficult to inject that drug because it's very viscous, it's very oily.
Yes.
So sometimes to, withdraw it from the vial itself, you may just not be able to withdraw it from the vial. You actually have to take a 21 gauge needle to actually pull it out. You may just be at 0.05. It's so difficult at times. You may not even get the small, at the tip of the needle, you will not get the drug almost, because it is just touching at 0.05. So sometimes you will end up giving an air bubble in the eye, for these patients, which is one beautiful thing with Eylea, because I'm so happy the way they are so lenient in that vial.
I
I'm
know.
at 0.15. I mean, yes, obviously, I've never taken advantage of this particular fact that it is 0.15 in the vial, and you would divide it between two patients, and that should not be done. And that is something that I will tell everybody, each and everyone in this group here, because it is so beautiful when you can actually go to, withdraw it properly, and then you will have the tip of the needle with one drop, and you are exactly injecting the right dosage in the eye, which is so important. So faricimab, yes, this big issue is there about getting the drug. Second is also what I saw with faricimab is that it doesn't give you that wow effect on the first or the second injection. So faricimab takes a little while to act. That is for sure. It is not immediately the way, you will get a response with Eylea. Over 3, over 4 injections, you'll start noticing some kind of a change that happens in diabetics, and the edema starts coming down. But I'm not going to be very confident about faricimab, because it's just been used in hardly 1 or 2 patients. That way.
So I guess there is no any further questions from the group. So like we are good to close the meeting then.
Yes.
Sushil bhai?
Thank you
Yeah.
so much.
Yes. So that brings us to the end of today's presentation. I would like to express sincere thanks to both the esteemed speakers, Dr. Sonal Jadhav and Dr. Ruchi Wala, for their insightful and excellent presentations. Your expertise and valuable perspectives have greatly benefited this meeting, ma'am.
Thank you, Sushil. Thank you, Yash. Thank you so much.
Thank you so much,
Yeah,
ma'am.
So
and I
much,
would
both
also
of
like
you.
to thank all the participants for joining today's meeting, and we truly appreciate your time and presence. Thank you once again, and wishing you all a pleasant evening.
Yes.
Thank you.
Thank you so
Same to
much.
you.
Thank you.
Thank you so much, everyone.
Good night, ma'am.
Good night. Good night. Thank you, Ruchi. Good night. Thank you.
Akash, we are good to close the meeting.
Yes, sir.